Dr. Vishal Rastogi to speak on coronary interventions in chronic total occlusions, which is another big challenge for interventional cardiologists of today. Dr. Vishal is a consultant interventional cardiologist at Escort Heart Institute, and he specializes in the imaging of coronary arteries using the OCT and OCR.
Respected chairpersons, dear friends and colleagues, first of all I would like to thank the organizers for inviting me for this beautiful conference at this beautiful place where you can have a feast of academics along with spiritual wellness, and you can have overall development of medical sciences. Coronary interventions in total chronic occlusions are one of the most challenging topic today, and a lot of us would either refer these patients for surgery or treat them medically because we don't feel that we are competent enough to deal with them. So first let me talk about why we should open these CTOs, what is the need and what is the benefit to the patient. This is the landmark trial which is published in New England Journal of Medicine, which is the occluded artery trial, and we often say that the occluded arteries are not to be opened because there is no benefit based on this trial. But we must remember that the occluded artery trial was not about chronic total occlusions. In OAT trial, the median duration of occlusion was 8 days, mostly after a large atrial infarction, 7 to 28 days after the infarction, and patients did not have ischemia and the viability was unknown because it was not tested. While in CTOs, they are of longer duration. We know that up to 50% of these patients have not had prior myocardial infarctions, so probably they have not infarcted yet. Patients should be symptomatic and there should be proof of ischemia, and viability must be demonstrated before we embark on such a risky procedure. The presence of a CTO and whether we are able to open it or not open it in a patient who's got multivessel disease has a bearing on cardiac survival. You can see in this curve that patients who have successful CTO revascularization have 91% survival, while those who we could not open had 87% survival with a bordering p-value. But at the same time, if the revascularization is complete, 94% patients had long-term good survival, while 83% patients had bad survival if the revascularization was incomplete. It is of prime importance to completely revascularize these patients. But what is a better option? Is bypass surgery a good option if we think about complete revascularization? In this study by Patrick Serruis, which was the bypass CRT trial, in 266 patients of total occlusions, 12 were not treated by bypass surgery and 81 were not bypassed. Overall, 68.1% patients who had total occlusions were successfully bypassed. The reasons why they were not bypassed was because either the target vessel was very much diseased, the conduit was inadequate, or it was too small, they were not able to find the vessel, or there could be other reasons. But overall, it was not a great success. And even those who could be bypassed, only 26% patients had bilateral edema-lima, or 20% patients had complete arterial revascularization. We know that vein grafts fail, and though this study is not for the success or failure of the vein grafts, it showed pre-treatment of grafts to improve patency and published in 2005. But here you can see that more than 40% of vein grafts occluded within first 18 months. Again, this is a study to compare on-pump with off-pump bypass surgery, and here also you can see up to 50% vein grafts occluded when they were implanted to LCX or RCA. In Prague 4 trial, it was shown that the graft patency to LAD is excellent, but when it comes to RCA, it is only 24%. And you must remember that more than 50% of CTOs are located in the RCA. So bypass surgery is not the greatest of the options to treat these patients. But is PCI an option? Yes, it is an option, but we cannot do like we did in the Syntax trial, where out of 277 patients, CTO success rate was only 49%. So today the guidelines of ACC, AHA and SCI say that it's a 2A indication. PCI of CTO in a patient with appropriate clinical indication. Mind you, there should be appropriate clinical indications and suitable anatomy is reasonable when performed by operators with appropriate expertise. So it is very important that the operators of appropriate expertise who have more than 80% success rate should be attempting these CTOs. So what should be the strategy? If the patient has got prior myocardial infarction, viability testing is required. If there is no prior myocardial infarction, then you have to have a proof of sufficient ischemic territory, which should be to the tune of 10%, depending on symptoms. In patients who have multivessel disease with CTO, you should aim for complete revascularization and not just treat the non-CTO lesions and leave it. And in fact, first you should treat the CTO. According to 2012 appropriateness user criteria, if the patient does not have a high risk finding or is a low risk finding on non-invasive study or is asymptomatic, then treatment of CTO of one vessel is inappropriate or of indeterminate category. But if the findings on invasive study are high risk, or if the patient has got class 3 or class 4 symptoms, then it is appropriate to treat these lesions. Briefly, I would be dwelling on the technology, on the techniques and how to open this CTO. The enemy is that this plaque which is there has hardened over a period of time. You can see on the left panel, this is a 1.5-year-old CTO where you can still find some microchannels and very, very little calcium on the border. This dark part is the calcium and these are microchannels through which you can enter. While in a lesion which is 5 years old, you can hardly find any microchannel. These are all calcified areas which are very hard and it will be very difficult to penetrate these lesions. So what are the predictors of success? Procedural success can be expected if it is a functional occlusion or it is a early occlusion, that means less than 12 weeks old. If it is a short duration, short length, if the stump is tapered, if there is no side branch where the lesion is starting, if there is no bruising collateral, and if there is no calcification. While if the reverse is true, then it is highly possible that by traditional technique you will fail. So one should be prepared with a lot of factors once we start to open this CTO. One should avoid ad hoc PTCA of these CTOs. One should decide and one should take time. It is very important to very, very carefully assess the diagnostic angiogram. You see the proximal and distal caps, vessel paths, collateral sourcing from where the collaterals are coming, and the calcium. Always do bilateral injections. Mostly the RCA collaterals will be coming from LAD and the LAD collaterals will be coming from RCA. So you have to inject into the both coronaries, both sides simultaneously to see the complete course of the lesion and the distal vessel. To minimize guessing, one should prior do a CT coronary angio or one can see by IVUS. Guide support is of paramount importance because if the guide is hanging, then whatever force you give with the wire, it is not going to be transmitted to the lesion. It is of paramount importance that you should set safety working parameters. The contrast that I am going to give to this patient and the radiation that I am giving to this patient, and you must set that if the contrast amount exceeded this point, then I would be abandoning the procedure and come back another day. It's all about wires. And there are antegrade wiring techniques and retrograde wiring techniques. Antegrade wire techniques are single wire, which is drill versus penetrate versus probing, which is also known as sliding technique, and parallel wire technique. Well, there are retrograde wire techniques and IVUS guided wiring. It is very important that you give a very, very short tip curve. The primary bend should be less than 30 degree and it should be 1 to 2 millimeter from tip. If it is necessary to enter the side branch, or if it is necessary to give a larger curve, it is important to give secondary curve rather than give a smooth curve or a large curve. If you found that a wire has entered subintimal space and you are not able to guide it into the main vessel, don't withdraw it, leave it there, use another wire which is known as parallel wire and redirect it to the true lumen path from the point you think that the other wire externalized. So first wire serves as a marker and it obstructs the entry to the false channel, while the second wire, which is usually a wire with a greater tip stiffness, is redirected to the true lumen. Here is an example that you can see that 4.5 gram miracle wire is outside, so you direct a 12 gram wire from the point of exit and you can enter the true lumen. So what is the typical antegrade wiring strategy? First, you should use a probing technique, which is a soft polymer wire. Fielder XT is excellent soft polymer wire, and you can probe the lesion and find the microchannels. If you are not able to find, then you should go to controlled drill technique by miracle 3 gram. You should be drilling the lesion very, very slowly. But you should not still force it. You should just drill it and it should pass. If it fails, and you see that the lesion beyond this is tortuous and there is a long missing segment, then you should not go for penetration technique. You should escalate the strength of the wire to 12 grams, but continues with the controlled drill technique only. But if you know the vessel path, that this is the vessel path, then you can really take a very hard wire like Confluenza Pro and you can penetrate this lesion and achieve the success. But if you enter the false lumen, then it is prudent to leave this wire here and go for parallel wire technique, and even if that fails, then I think one should go to retrograde. What is the retrograde technique? I would not go into detail of this technique because it's very, very complex, but there is, you can access the CTO from retrograde route by a collateral channel, which is a septal perforator. Most safely you can use a septal perforator, and you should avoid epicardial collaterals, because if you perforate them, it can cause tamponade. You should use a hydrophilic wire and a microcaster with a channel director through which you can pass the hardware. Now, once you have reached the site or the distal cap distally, then you can use this wire either as a kissing wire, where you can drill both the wires and these wires can meet in between, cause kissing wire, the antegrade and distal wire, or you can cross the retrograde wire and then dilate this channel and then externalize the wire into the aorta. And then now once you have dilated the channel, you can pass a antegrade wire. Otherwise, if you are not able to do that, then you can do a cart technique where you cause a dissection, subintimal dissection into the retrograde channel, which causes the lumen to be large enough so that the antegrade wire can now puncture into that particular area. So this is a schematic diagram. Here also you can see that you need bilateral injections, but now both these injections are through a guide because you are taking assembly into the coronaries. So suppose there is a CTO segment in this RCA, and this is your guide, which is through which you are getting a antegrade wire, and then you can see from the LED you are finding a collateral channel through which you are taking a retrograde wire and you are taking this wire till the distal cap, and now you can apply these techniques which I just discussed. So just to give you the evidence is from registry. Then we don't have large database where we can say that opening CTOs is beneficial. However, the data is now overwhelming. Successful CTO in patients with significant ischemia and or symptoms seem to be associated with improvement in ischemia, symptoms and outcomes. Currently, the guidelines give it a class 2A indication. But one must be cognizant of the cost, because the cost can be exorbitant in these patients. You may end up using 1, 2, 3 or 4 stents and other devices, and then of course the complications are enormous. So one should be respecting the impact of radiation effects and potential renal dysfunctions. One should be prepared to do pericardiocentesis if you cause a wire-based perforation. Regarding the technique, one should have a meticulous preparation. One should study the angiograms very, very carefully. Always use 2 catheters. You can use IVUS if needed. You must set safety parameters, otherwise you may just keep working until the artery is open and by the time the patient may be dead. You have to recognize why the wire is failing, and according to that you should base your escalation technique. Either it should be a rapid wire escalation technique, or if it is failing because it is not able to find the lumen, then you can use a parallel wire technique also. Stop and reassess before distal cap. Use wires and techniques that work well for you. Don't use something which is being promoted right now. You should use other techniques like anchoring techniques by which you can stabilize the guide support and that can help you with penetration more. You must have a good toolkit because you are going to need a lot of hardware. So you should know a lot of technique and you should be ready to use it also. Thank you.
Thank you very much, Dr. Vishal. I mean, that was a very good talk. The only thing, if there are any questions, it's okay. Otherwise, we can go for the next presentation because we have very little time. Are there any questions?